Surgical Repair Lecture. Acute Embolic Mesenteric Ischemia. When the diagnosis of acute mesenteric ischemia is made, fluid resuscitation should be commenced immediately to enhance visceral perfusion. Electrolyte abnormalities should be corrected and nasogastric decompression initiated. Systemic anticoagulation with heparin may be started to prevent further thrombus propagation. Significant metabolic acidosis not responding to fluid resuscitation should be corrected with sodium bicarbonate. Broad-spectrum antibiotics should be administered immediately. Unless contraindicated, patients should be anticoagulated with intravenous unfractionated heparin. A central venous catheter, peripheral arterial catheter, and Foley catheter should be placed for hemodynamic status monitoring. Prompt laparotomy should be done for patients with overt peritonitis. The operative management of acute mesenteric ischemia is dictated by the cause of occlusion. It is helpful to obtain a preoperative mesenteric arteriogram to confirm the diagnosis and to plan appropriate treatment options. Patients in a moribund condition with acute abdominal symptoms should undergo immediate surgical exploration, avoiding the delay required to perform an arteriogram. The primary goal of surgical treatment is to restore arterial perfusion with removal of embolus from the vessel. Upon opening the abdomen, it often reveals a variable degree of ischemia from the mid-jejunum to the ascending or transverse colon. Two approaches can be done to secure SMA: direct approach to the SMA or through the retroperitoneal area. In the direct approach, the transverse colon is lifted superiorly and the small intestine is reflected toward the right upper quadrant at the junction between the third and fourth duodenum beneath the pancreas. The mesentery contains the SMA and can be directly approached here. The retroperitoneal approach is done by incising the retroperitoneum at the lateral of the fourth portion of the duodenum and rotating the bowels, medially exposing the SMA. After the SMA is identified and controlled by vascular clamps, transverse arteriotomy is done and embolus is removed by standard balloon embolectomy catheter. Isolating the individual distal, jejunal, and iliac branches at the root of the mesentery, in the event if the embolus lodges distally, can be done to do the comprehensive thromboembolectomy. Once the flow in SMA is restored, intestinal viability must be checked and non-viable intestines must be resected. Here, bypass to the distal SMA through mesentery root. The left common iliac artery was used. Three methods used to evaluate intestinal viability: intraoperative intravenous fluorescein injection, inspection with a Wood's lamp, and Doppler ultrasound used to assess arterial pulsation at the antimesenteric area. A second look should be considered 24 to 48 hours after embolectomy to reassess the extent of bowel viability. Non-viable intestines must be resected after the second look. Damage control surgery is an important adjunct for patients who require intestinal resection due to the necessity to reassess bowel viability and in patients with refractory sepsis. Planned re-laparotomy is an essential part of acute mesenteric ischemia management. The findings of massive gut necrosis requires careful assessment of the patient's underlying comorbidities and advanced directives in order to judge whether comfort carries the best treatment. AMI is a true surgical emergency. First and foremost, important evidence is a high index of suspicion based on the combination of history of abrupt onset of abdominal pain, acidosis, and organ failure. This clinical scenario should prompt imaging CTA in order to establish the diagnosis. In parallel with rapid resuscitation and after careful assessment of the CTA, the patient should be explored to assess bowel viability, re-establish vascular flow, and resect non-viable bowel. Subsequently, the employment of damage control techniques and continued critical care resuscitation is essential. Planned reassessment of the bowel with further resection or anastomosis and stoma as needed is integral. Close cooperation between acute care surgeons, radiologists, anesthetists, and the vascular surgeons is essential. Research done by Dr. Ray J. Libakin. Please subscribe to my channel and click the notification bell for more updates. Thank you.